Today we are going to discuss arthritis in children, and what I want to emphasize is that arthritis in children, like many other conditions, is essentially about pattern recognition. If you are able to identify the pattern that the child has, we are often able to diagnose the condition and appropriately manage that condition. To highlight this fact, I'll be using a case-based discussion method. I'll be discussing few cases which will highlight the importance of identification of patterns in children with arthritis. So arthritis is one of the common manifestations with which children present to our clinics. Apart from features like fever, body pains, or easy fatigability, I would say arthritis is one of the manifestations which is quite common with which children present to our OPDs or clinics. So to highlight the importance of pattern recognition, as I already highlighted, that I'll be discussing few cases. So moving on to the first case, who is a 10 years old boy who was brought to us with a history of fever which was there for 3 weeks. Fever was up to 102 degrees Fahrenheit, not associated with chills and rigors, used to occur daily and subsided with medications. Along with this fever, the child was having swelling and pain of multiple joints, which was also there for last 3 weeks. And this involvement of joint started from right ankle. The pain and swelling in right ankle persisted for initial 5 days and responded to the treatment that he received in the form of non-steroidal anti-inflammatory drugs. However, his left knee got involved 2 days later, and when he presented to us, he had both knees and right wrist involvement. So, looking at this case, the points that which must be looked for, carefully, are age of the child. So, whenever we have a child with arthritis, these are the points which must be taken care of. So, they are age of the child, the duration of symptoms, is there any symmetry of joint involvement? Is the joint involvement deforming or not? And are there any systemic features? So in this case, if I have to describe this child in a single phrase, I can describe this child as a 10 years old boy presenting with acute onset migratory polyarthritis, and in addition, he responded very well to whatever treatment he was given in the form of non-steroidal anti-inflammatory drugs. So most likely diagnosis in this case is acute rheumatic fever. The child was managed as acute rheumatic fever and responded well to treatment, started on penicillin prophylaxis. So if you look carefully, this single phrase, a young boy with acute onset migratory polyarthritis, makes the diagnosis of acute rheumatic fever very simple. So similarly, whenever we have patients in whom we are able to, uh, discern the pattern, then it makes easy for us to make the diagnosis. Similarly, moving on to the next case, who is a young boy, 2 years old boy, refuses to walk and was having high grade fever along with rigors, which was there for 2 days. Sig- uh, Very characteristically, he had significant pain whenever someone tried to move his limb. So he was having significant pain with passive movement, and the child was sick looking. So if you go back to the features that I described previously, he's a young boy, 2 years old boy. The duration is only 2 days. There are systemic features in the form of high grade fever, sick looking child, and characteristically significant pain on passive movement of right leg. So this classically fits into a patient who is having septic arthritis. So septic arthritis, we must remember that is a clinical emergency often seen in young children. We also must know that incidence of septic arthritis decreases as children grow. So it is often seen in young children, is associated with redness, local increase in temperature over the joint. Pain with passive motion is the hallmark, as we described in the case that we discussed. The child tries to keep the joint in a position so as to maximize the intracapsular volume. Suppose a child is having septic arthritis of the hip joint, so he will keep the limb in a flexed, abducted, and externally rotated position so as to increase the intracapsular volume. So flexed, abducted and externally rotated limb you will find in a child who is having septic arthritis of the hip joint. Joint aspiration followed by gram staining and culture of the fluid that we obtain are confirmatory for diagnosis of septic arthritis. Septic arthritis, as I said, is an emergency, has to be taken care of in emergency. However, whenever we have a child who is more than 2 years of age, we should think twice about making a diagnosis of septic arthritis. As I already told, the incidence of septic arthritis decreases with age and it is often seen in young children. So most of the patients of septic arthritis you will find in children below 5 years of age. If more than one joint is involved, it is highly unlikely that the child will have septic arthritis. So a grown-up child, more than one joint involved, we must reconsider a diagnosis of septic arthritis, and whenever in doubt, we must aspirate the joint before proceeding with an emergency arthrotomy. So whenever in a doubt, we can always aspirate the joint, get a gram stain and culture of the fluid that is obtained done, and then we can decide for emergency arthrotomy. Suppose if the child is having these symptoms for more than few weeks, it is very unlikely to be septic arthritis, and in that case, an emergency arthrotomy can always be avoided. Now coming to proper juvenile idiopathic arthritis. So juvenile idiopathic arthritis, as the name suggests, occurs in juveniles. So the diagnostic criteria or classification criteria say that the age has to be less than 16 years, means juvenile. It has to be there for at least 6 weeks, which means it has to be chronic arthritis, it is idiopathic, and it has to be arthritis. So juvenile idiopathic arthritis. Arthritis for JIA classification means swelling of a joint. So any swelling of a joint which fulfills these criteria, age less than 16 years, at least 6 weeks, can be labeled as arthritis for this purpose, or any two of the following signs of inflammation. So either swelling of the joint or any two of the following features of inflammation in the form of limitation of movement or function, pain on movement, or warmth over the joint. Either swelling or two of these three makes it arthritis. Age less than 16 years, at least 6 weeks, arthritis in the form of these features. Now coming to classification of juvenile idiopathic arthritis. This looks somewhat complex, but actually it is not. Essentially, the classification is this classification is based on ILAR system, or International League Against Rheumatism, ILAR classification system. So essentially the classification is oligoarthritis, polyarthritis, which is of two types: rheumatoid factor positive, rheumatoid factor negative, and systemic juvenile idiopathic arthritis. So these three types we are already aware of: oligoarthritis, polyarthritis, which is of two types, and systemic juvenile idiopathic arthritis. In addition, we have specific types like enthesitis related arthritis and psoriatic arthritis. If a patient fits into more than one category or does not fit into any of these categories, it is labeled as undifferentiated arthritis. So making it simple: oligo, poly of two types, systemic, enthesitis related, psoriatic, and undifferentiated. So again, coming to cases, we had a 2.5 years old girl who walks into the OPD with a limp. There was a complaint of swelling of right knee with pain for past 2 months. There was no history of fever. The child was active throughout the day. However, during the early morning hours, she was somewhat stiff, and it was difficult for her to move in early mornings. When examined, we found that her right knee and left ankle were swollen. The other joints, however, were normal. So again, coming back to those features that we discussed, she's a very young girl, 2.5 years old girl. There is no fever. She's active. So this is what makes it likely to be a type of juvenile idiopathic arthritis. When investigated, found to have elevated ESR, CRP was normal, MAN2 non-reactive, slightly elevated platelet count. So this is oligoarthritis, juvenile idiopathic arthritis of oligoarthritis kind. Oligoarthritis, we call it whenever we have less than 5 joints involved, often occurs in girls who are of preschool age. So occurs in very young children, very young girls. Most common joint involved is knee, and often the child is well. The only problem is limp or swelling that we notice. We must remember that isolated upper limb and hip involvement are very less common. So you won't find a child of oligoarthritis having only elbow or wrist swelling. They often come with ankle or knee. Isolated upper limb and hip involvement are less common. So in this case, the pattern is usually large joints, predominantly lower limb, and a young child. So usually large joints. So more than the number, I would say the pattern is more important. You will not find oligoarthritis children having small joint involvement. They do not have involvement of the uh, interphalangeal joints. So they have predominantly large joint involvement, less than 5, occurs in young girls, and most common joint is knee. Isolated upper limb and hip involvement is less common. Extremely important for us to know is that whenever we have a child with oligoarthritis, the only important investigation I would say is antinuclear antibodies. Antinuclear antibody positivity is highly associated with occurrence of uveitis in these children. Uveitis is asymptomatic. The highest risk of uveitis is in young girls who have oligoarthritis and are antinuclear antibody positive. And that is why regular screening with slit lamp is mandatory in children in whom we diagnose oligoarthritis. So we get an ANA done. If it is positive, they are at a very high risk of developing uveitis, which unfortunately is asymptomatic. So screening has to be done and which has to be regular. Coming on to the next case. Now this is a grown-up girl, 12 years girl, presented with history of additive arthritis involving small joints of hands now. Feet and later large joints for the past 6 months, occasional intermittent fever, arthritis is deforming, subcutaneous nodules are also present. So classical example of rheumatoid factor positive polyarthritis, deforming arthritis, symmetric arthritis, small joint involvement, subcutaneous nodules. So these are some characteristic features of rheumatoid factor positive polyarthritis. Uh, According to the classification criteria, more than 4 joints are involved. But again, I would say more than number, it is the pattern that is more important. RF positive polyarthritis again is more common in girls, however, in adolescents, unlike oligoarthritis. It resembles the adult rheumatoid arthritis that we see, symmetrical arthritis of both large and small joints. So symmetry is very important for rheumatoid factor positive polyarthritis. Deformities are seen as compared to rheumatoid factor negative polyarthritis, which is more akin to oligoarthritis, often seen in young children and in children 6 to 12 years of age. 2 to 4 years, 6 to 12 years. So again seen in young children, girls more than boys, less symmetrical, more of cervical spine and temporomandibular joint involvement. Knees, wrists and ankles are commonly involved. So as you can see, this is more like oligoarthritis that we described. Less symmetrical, less of small joint involvement. So these patterns help us to identify these patients. Now moving on to the next case, a 5-year boy presented with high spiking fever, a rash which was there. The rash became more prominent whenever the child used to get fever. This is the fever chart that is visible on this screen. The fever chart, as you can see, is daily high spiking fevers. On examination, he had swelling of both ankles and knees, which was there for 1 week. And on examination, he was having hepatosplenomegaly. Now, looking at this child, this can be anything, like any infection can present like this, fever for 2 weeks, swelling of both ankles and knees, hepatosplenomegaly. So infections and malignancies are very important differentials of this condition, which is known as systemic juvenile idiopathic arthritis. The classification criteria say that arthritis in any number of joints along with fever of at least 2 weeks duration. So unlike 6 weeks, which is there for usual JIAs, we have 2 weeks of fever along with any one of the following: evanescent rash, generalized lymphadenopathy, hepatosplenomegaly, serositis. So these features can be seen in many other conditions as well. And to add more to the complexity, arthritis may not be there in these children when they present to us. They may only be having fever with, say, generalized lymphadenopathy, hepatosplenomegaly. So it is not easy to make a diagnosis of systemic GIA, but when we have eliminated everything that is possible, whatever remains must be the truth. What does this mean? This means that we have to exclude all the other conditions that can be thought of in such situations. So when we have excluded all kinds of infections, malignancies, then we make a diagnosis of systemic juvenile idiopathic arthritis, because the presentation is such that these manifestations can be seen in many other conditions. So systemic GIA, we must remember, that is a diagnosis of exclusion. Now we have a 10-year-old boy who presented with swelling of right ankle, left knee, which is there for 1 year. There is a history of redness of eyes twice in last 6 months, and on examination, we found that he had point tenderness over insertion of tendo Achilles. So this is a characteristic. So you must make note of the age of the child, the gender of the child, history of redness of eyes, and tenderness over insertion of tendo Achilles. So this is classical enthesitis related arthritis. The classical pattern is adolescent boys, predominantly lower limb, asymmetric arthritis. We find acute symptomatic uveitis. Now here the uveitis is usually symptomatic, which means acute redness, painful, watering eyes, which is seen in about 10% of these patients. HLA-B27 is positive in around 90% of these patients of enthesitis related arthritis. So the pattern here is adolescent boy, predominantly lower limb, large joint, asymmetric arthritis. So these are often ERA, and this is quite common subgroup of GIA which we see in our clinics. Moving to the next case, 5-year-old girl presented with the right knee arthritis, which is there for 3 months. So a young girl, right knee arthritis. On examination, it was also seen that distal interphalangeal joint of left index and middle fingers were involved. Father was being treated at dermatology department with some topical creams for last 8 years. So the characteristic features that we see in this case are involvement of distal interphalangeal joints, which is often not seen in any other kind of arthritis. And we must have a look at the nails of such children to look for this finding, which is nail pitting. So this is classical psoriatic arthritis. So distal interphalangeal joint involvement is commonly seen in psoriatic arthritis and not in any other kinds of juvenile idiopathic arthritis. Psoriatic arthritis usually has 2 types of presentation. So if you closely look at this slide, you will find that these patterns mimic other types of GIAs. So the 2 types of presentations are, one is predominantly lower limb asymmetric oligoarthritis, who are ANA positive, have uveitis, dactylitis, and DIP involvement. And the other one is an adolescent boy with increased risk of spondyloarthritis. So on the left side, you see that this pattern fits, seems like oligoarthritis, a young girl who is ANA positive, uveitis, dactylitis, DIP involvement. So this pattern is seen in psoriatic arthritis in young girls. However, psoriatic arthritis in adolescent boys usually present with ERA-like presentation who have increased risk of spondyloarthritis. So this is all about patterns in childhood arthritis. We must remember that these phrases. So whenever we have a young girl, predominantly lower limb, few joints are involved, the diagnosis often is oligoarthritis type of GIA. The investigation that is very important is ANA, and screen these children, young girls, for uveitis. The next pattern is grown-up boy, lower limb, few joints. Now we know that this is enthesitis related arthritis pattern. A grown-up adolescent boy, predominantly lower limb, asymmetric, very few joints. Uveitis in this case is acute symptomatic uveitis. The next pattern is grown-up girl, multiple large and small joints, symmetric deforming arthritis. I'm sure all of us now know that this is a characteristic pattern of rheumatoid factor positive polyarthritis, and it has a poorer prognosis as compared to oligoarthritis. Both large and small joints, dactylitis, distal interphalangeal joint, I'm sure now we know that this is psoriatic arthritis. We must ask for history of psoriasis in the child or family, and we must look for nail pitting as well. Any age, high grade fever, evanescent rash, systemic JIA is a diagnosis of exclusion. So, pattern recognition, I would again say, is the essence of diagnosis of arthritis in children. Thank you.